Okay, we're going to continue with our afternoon session, another 15-minute lightning round here. Again, this is Dr. Mike Willard from Texas A&M, and the next section is going to be entitled Ileoscopy. So, thanks again, Dr. Willard.
I have no conflict of interest to announce. This is a case. This is your typical 10-year-old male castrated domestic short-haired cat that's got vomiting, diarrhea, and weight loss, right? Old cat, weight loss, GI signs. And, you know, once you eliminate extra alimentary things like hyperthyroidism and stuff, you get down to the GI tract, right? I mean, we did CBC profile, UA, T4, all that's okay. The ultrasound was, and I quote, essentially normal abdominal ultrasound. Endoscopy looked pretty good. And when we biopsied the duodenum, we came back with, and I quote, lymphocytic and mild eosinophilic duodenitis. Now, this is the intestine. And yes, there are extra lymphocytes. And as you look at this, what you should realize is this is garbage, useless trash. Here you have a piece of intestine that's got some extra cells. Folks, when your nose hurts, it makes mucus. When your eyes hurt, they make tears. When the gut hurts, it makes lymphocytes. All the gut is a big lymph node with a hole in it that absorbs food. And when a lymph node gets upset, it makes lymphocytes. This tells me, oh my, the gut is irritated. The cat's got diarrhea. I got that much figured out, okay? Now, and especially the trouble here is the mild nature of the histologic lesions don't correlate with the severe nature of the signs. Now, for a long time, people have said, well, gee, Mike, that's because you can't correlate histology and clinical signs. Well, maybe, but it also might be that when you're trying to correlate the two, you took the wrong sample. It just seemed, we always said, oh my gosh, it's small bowel biopsy duodenum. Well, guess what? There's a lot more to gut than just the duodenum. In this particular cat, we also decided to take some ileum. This is the ileum. And you may not be a pathologist, but if I can put these side by side, can you tell there's a big difference between that and that? That's meaningless, useless reactivity. That's lymphosarcoma. And we've seen this quite a few times, and I want to talk to you about ileoscopy because we've found that we've made a lot of diagnoses with ileoscopy that we would never make with gastroduodenoscopy. Now, just briefly, this is a paper we did with Michael Day in Bristol. We took a look at a bunch of patients. 30 of them had lesions. Only 8 out of 30 animals had the same lesion in the duodenum as they did the ileum. And in particular, we found that if you just biopsied the duodenum, you would have made a diagnosis 60% of the time. But if you just biopsied the ileum, you would have made a diagnosis 80% of the time. My point is, we get a lot of diagnoses out of the ileum. And sometimes they're similar, sometimes they complement each other, sometimes they are completely, totally different. Now, a few things about the technique. When you're doing ileoscopy or even colonoscopy, typically the animal's in left lateral recumbency. So the descending colon's down here. You want the ascending colon and the ileocecal colic valve area on top so that any fluid that comes in drains down here and gets out of the way. The real problem with this technique is all the stuff coming out of the small bowel that obscures vision. So if we want to be able to go up here and find the ileum and go into it, we have to have a really clean animal. First, I want to fast them for at least 36 and preferably 48 hours if I can. Now, as far as cleaning out the colon goes, yes, I know the lavage solutions work best. They also have to be given by stomach tube. They're also more expensive. If you're doing a big dog like a St. Bernard or a Great Dane, yeah, the lavage solutions are best. But the problem most people have is they don't love doing enemas. You've got to love doing enemas to do them right. And what we say is if you're going to give an enema, you give high, hot, and a whole lot, okay? When you're doing a small to medium-sized animal, I mean, you put that tube as far up the colon as you can, and you just start putting in warm water till it's shooting out the back. And you do that repeatedly. And if you'll do that repeatedly, you get a pretty clean prep. Typically, we'll do like 2 or 3 enemas the night before, a couple enemas the morning of, and wait 3 or 4 hours and do it. We also give some laxatives, some bisacodyl that night before. So for small and medium-sized animals, enemas and laxatives usually do a very good job for us. For the really big animals, lavage solutions probably are the best. Now, this is your typical ileocolic valve region. That's the entrance to the cecum. That's the entrance to the ileum. Now, the trouble is you can see a lot of different appearances here. Here you just see 2 holes, okay? This structure up here, the ileocolic valve, is relatively dynamic. It may look like that. It may look like that. Or it may look like that. Or it may go back and forth, okay? It's a very dynamic structure. Now, the real problem is a lot of times it looks like that. And that's because, why? Because it's very hard sometimes to get everything out of the small bowel. And when you stick that scope up in the colon, you're stimulating the animal, and all of a sudden all this stuff starts pouring out of the ileum, obscuring your vision. This can make life difficult for a couple of reasons. Number one, the ileum usually gets more obscured than the cecum. And it's very common when people are doing the procedure, they don't see that hole because it's covered up. They just go right in here into the cecum, and then you find you're trying to make these impossible turns that you can't do. If you're finding that you can't go where you want to go, that's like a red flashing light. Dude, you're in the cecum. Dude, you're in the cecum. Back up. And you back up, and then you're going to have to find the opening here. Cats are a bit different. With cats, you have a blind pouch. That's the cecum in the cat, and that's the ileocolic valve. And the thing you've got to realize about cats is the entrance to the ileum in cats is so small that unless you have a very, very expensive pediatric gastroscope, which is about a 5.2 or 5.6 millimeter outer diameter, which is pretty pricey, you're not going to put a scope up there. We'll talk about how to do that. Now let's go ahead and let's take a look at dogs first. Now here we have a dog, and we're going to go ahead and we're in the colon, and we're going to start heading up. And as we start getting up here, let's see. Now take a look. There, the big hole is the entrance to the cecum. There's the entrance to the ileum. Notice there's some goop coming out. That's what typically happens. Now this is actually a pretty happy day. The ileum is just wide open saying, here I am, have a nice day, okay? And so all you have to do is just pretend like it's a pylorus. In the case like that, all you have to do is pretend that it's a pylorus, and you go in. Now this is actually pretty nice. I wish it was always like this, but it oftentimes isn't. And many times the more you mess around up there, the tighter and tighter it gets. If unfortunately, and here we are, if unfortunately you see something like that, you can try to just push the scope in. Sometimes what you need to do is advance your biopsy instrument and use it as a stylet to find the ileum so that you can push in. I'd rather not do that, but sometimes you need to. Now then, you'll know you're in the ileum, you'll know you're in the right place because you're going to start to see texture, okay? Sometimes you're going to be slipping back and forth and you're not really sure whether you're in the cecum or the ileum. The ileum has texture. You've got villi. See those villi up there? It's got texture. That's ileum. And if you happen to get in and you're not sure and you see texture, don't pull out because like I said, the more you go in and out that ileocolic valve, the more upset it gets and the less likely you are to get back in sometimes. Now cats, what do you do in cats? With cats, what you're going to do is you're going to have to pass the biopsy instrument into the ileum like that. You're not going to get the scope. Now that's not always as easy as it seems. Now in particular, the problem that you have in cats, if you've got a short cat, when you take that scope and you flip up, you tend to take the tip and you flip it past the ileocolic valve so you can't see it. Therefore, we're going to do a walking stick procedure of sorts. Watch what happens next. We're going to come up here, and as we take a look, now there you have, there's the blind pouch where, that's the cecum. Oh, let's try that again. There's the blind pouch, which is the cecum. The ileocolic valve is back over here. Your scope is past it. So what we're going to do now is we're just going to take our biopsy instrument and we're going to gently push the cecum away. Now watch on top, watch right up here, and then all of a sudden, oh look, there's a hole. That's the ileocolic valve, okay? And so what we've done is we've pushed it away so that we can see it. And now you don't have all the time in the world, but you do have enough time to reposition the scope and take the biopsy instrument and just pass it up and get your biopsies. Now, some people don't like to take biopsies without seeing. You can get away with it here because the ileomucosa is so thin, it's very, very easy to get full thickness biopsies of the ileum. In fact, it's easier to get high-quality ileo biopsies than it is high-quality duodenal biopsies. The bigger the animal gets, the thicker the mucosa gets, and the harder it is to get full thickness of the mucosa. So what you want to do, this is why ileo biopsies work so well. We see more pathology down there, and we get better biopsies, so we can, in fact, see more. Now then, this is a little bit interesting, and I'll just mention this to you if you're ever trying to do this. In this case, you're going to see the opening is down here. The ileum is going to be ventral. Now, when you see that, I don't think you'll see this very often, but that is a cat with a short colon. You've got the short colon syndrome, where the colon's abnormally short. Colon should have kept going around like that. If you see that, that's short colon, you've got enough problems as it is. Now, I want to make some points. Bear with me. This is duodenum. Look, does that look anything like that? That's inflammatory. That's lymphosarcoma. That's a cat. Here's another cat. There's pretty severe inflammation, but this lymphosarcoma is worse in the ileum. How about this one? This is a dog. You can see villi. Someone would say, oh, Mike, you've got inflammatory bowel disease. Yeah, right. Here's the ileum. That's lymphosarcoma again. How about this one? Here you've got villi. That's pretty severe inflammatory bowel disease, right? There's the ileum. Lymphosarcoma again. Here's a good one. Here's what I really like it for. Here you see this is beautiful duodenum. You've got one cyst in a crypt, but that's all. This is the ileum. This is lymphangiectasia. We have had many cases where we found lymphangiectasia in the ileum and not the duodenum. And this is particularly important because when you are losing protein from these dilated lymphatics, if it leaks out of the duodenum, the rest of the jejunum and ileum may be able to absorb it. When it leaks out of the ileum, it goes into the colon and just waves bye-bye. And you have worse disease. Look, here's another one. Here you see, this is duodenum. You've got some crypt abscesses, but here's where you see the lymphangiectasia. Look at this one. Here you've got beautiful duodenum. You've got lymphangiectasia. Now, sometimes people say, Mike, why do you show me the same thing over and over? Part of the reason is I'm a parent, and I'm just used to saying the same thing over and over, you know? You know, a parent never says no. They say no, 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 no. You know, just repeat, well, I'm sorry. But anyway, but I want to show you multiple examples. This isn't like, oh, once upon a time I saw this. We see a lot of this. We see a lot of this. This is an animal which has, look at all those red dots, that's severe eosinophilic enteritis in the ileum only, not the duodenum. So number one, we see it. Now, not only might you see lesions in the ileum, but the ileocolic valve area just in and of itself can have lesions. Here we have the ileocolic valve. There you've got a mass right beside it. That's a tumor. How about this one? This was an animal which is bleeding profusely. I don't even know exactly what the lesion was, but all the bleeding was coming from the ileocolic valve. How about this one? This is necrosis. This is one pythium, which is a fungal infection, goes into the root of the mesentery and shuts off the blood supply, okay? In fact, if you're having a really weird day, this happens to be a cecocolic intussusception. Once again, only seen up in that region. That's actually the cecum that's pooched back out in the dog. You don't see that so much in cats, but you will see it in dogs sometimes. This is just a regular intussusception, just in the middle of the colon, up in the ileocolic valve area. And on very rare occasions, this is actually the freakiest, weirdest thing I've ever seen. This was an abnormal ileocolic valve. I remember I was putting this endoscope into this cat, and I was going up the colon, and all of a sudden I looked, and I'd put 80 centimeters of scope into this cat's colon. And I'm going, good gosh! Well, it turns out this cat had an anomaly where this ileum just went directly into the colon, and that was the reason for its problem. It didn't have a normal ileocolic valve. So in summary, the points I would make with you is, number one, ileoscopy. We've gotten a lot of diagnoses out of the ileum that we never would have gotten out of the duodenum. From my standpoint, if I've got a dog or a cat with small bowel disease, suspected small bowel disease, I routinely biopsy both. Now, some people have said, Mike, we don't get any difference in our diagnoses. Maybe that's the case, but I would also say this. Respectfully, I think we've got some very, very good pathologists who are very careful. And I promise you, I've shown you a bunch of examples here. I can show you more. This has happened to us a lot, okay? But remember, you need to get these animals really, really clean. Really clean, or you're not going to be able to see anything. I've got like a couple minutes if there are any questions. Going once, twice. Okay. Medora, you're up.
I've got one question.
Yes.
So, on those biopsies of the ileum versus the duodenum, have you been running in the cats with lymphoma? Have you been looking at the PCR-based tests?
Question, have we been doing PAR, looking for lymphoma? No, we haven't, because if I can get a histologic diagnosis of small cell lymphoma, that's a lot quicker and less expensive. For us to send off PAR, we're going to have to send that off. We're going to spend more time and more money. If, in fact, I had a laboratory downstairs that could run it for me anytime I wanted to, I probably would. But for me to send it off, if I can get a histologic diagnosis, it saves me time and money. Good deal. Okay, thanks.